Hi, I'm Frank Salenza, and I'm happy to share this information with you through the Global Institute for Dental Education. As a dual specialist, a periodontist from the University of Pennsylvania and an orthodontist from New York University, some interactions between the two specialties have always been of interest to me. More recently, through implant technology, there's been some interplay into the field of orthodontics that is very powerful and interesting, and that's what I'd like to share with you. Certainly, as specialists in other fields, the surgical specialties and the restorative specialties, we felt the tremendous impact of implant technology in the way we practice day to day. We feel that impact from the very onset of case identification, treatment planning, execution, and final result, and we had to relearn a lot of what we do to employ implant technology for the benefit of our patients. But my observation as an orthodontist was that the orthodontic specialty didn't really feel the impact of implant dentistry to the extent that the other specialties did. And so I feel that that specialty of orthodontics is poised now to realize dramatic transformation as we did, and I'd like to share with you my thoughts on how that might occur. So there are really two arenas which I feel this will occur in. First of all, the orthodontist historically has been involved with implants preparatory to their placement. If you have a case that is semi-edentulous and you know that the restoration will now involve an implant rather than a fixed prosthesis or a conventional dental restoration, the thought is a little different, and the orthodontists are certainly involved in that realm, and we'll share information there. Secondly, there are interactions whereby an orthodontist can utilize implants for the benefit of his mechanotherapy and as part of his appliance, and that's a particularly exciting arena that we'll also look at in a few minutes. So if we consider some of the areas, interactions preparatory to the implant placement, now the orthodontist has a case that he's setting up to receive an implant. There are things that he might do to manage the spatial relations of the teeth to receive that implant after his orthodontic therapy, and there are things he might do to modify tissue utilizing orthodontic movement as a site development tool. When we consider how an orthodontist might use an implant as part of his mechanotherapy, there are techniques known as direct and indirect anchorage, which are very powerful modalities, and we'll take a look at that as well. So let's start with some of the thoughts I have on managing spatial relations. Again, we're dealing now with an orthodontist who receives a case and in his conventional thinking is setting the case up to receive an implant. So the error that many orthodontists make, I think, is to not function as part of the implant training team. Many times the orthodontist is the first one to see the patient. He takes over the treatment planning and the setup of the case and may not even introduce the implant surgeon until his work is complete, until the case is set up. And there are a lot of problems he may encounter if he functions that way. I feel, and my message to the orthodontic community is that they need to be more interactive as part of the treatment planning team from the beginning. For instance, take a look at a typical case like this one. This patient is 24 years old. She was in orthodontic treatment for almost a year for the purpose of setting up the spatial relations to receive an upper right lateral incisor implant replacement. And so the orthodontist was functioning individually for that time period, set the case up, and at that point made the referral to a surgeon to receive an implant. And when the surgeon sees the case, he understands that this is going to be an implant replacement. The orthodontist provided the space at the level of the clinical crown, knowing that he needed 6 or 7 millimeters of space, and then makes the referral. The surgeon takes a periapical radiograph and realizes that this is not an implant situation, that the setup is not right. And the error that was made here was, one, in treatment planning, but also in diagnosis, that the orthodontist may not have been treating this case to the radiograph as we would expect. The orthodontist frequently uses crown contour and shape as his reference point, and he may use the incisal edge of those incisors as his reference point to do his bracket placement and parallel the teeth. Well, the problem with that is that the incisal edge of that upper right central incisor is not the correct incisal edge. That incisal edge has been subject to years of attrition and uneven wear, masking the root parallelism that was not evident in this case. So if the brackets are placed on those teeth according to the incisal edge, you will not parallel roots appropriately. And in the case of implant placement, exact tooth position and parallelism is of paramount importance. Were this case to receive a 3-unit bridge, well, then there's some leeway built into it if the teeth are prepared. But what I'm pointing out here is that now that implant placement is indicated, it is much more conservative to natural tooth structure, so ideal and exact tooth position is becoming more important. So we have to go back and retreat this case, which is problematic to that patient because she already had a year of orthodontics, and now we have to reparallel these roots. And tipping that apex of the right central incisor towards the midline is a very difficult movement. We need to get the root space interradicularly. So here I'm using brackets that feature a vertical slot for the purpose of employing root springs, uprighting springs that you see in the appliance there. And you can see the deflection in that arch wire and how it's affecting root torque to open that interradicular space for implant placement. Some 9 months later, when the roots are parallel, now look at the incisal edge reference points, thereby obliterating the attrition that the tooth was subject to. Now that's easily adjusted away for, but that's what it would take for that tooth to be properly paralleled, allowing implant placement with good interradicular bone and subsequent restoration. So the important point is that the orthodontist, in preparing a case to be set up with the correct spatial relations, not just at the coronal level, but interradicularly, needs to be treating these cases to the radiograph in addition to the clinical situation, not to the clinical situation entirely, as he's historically trained to do. I like to teach that the most important visit during an orthodontic case is the visit when the appliance is placed, when the brackets are bonded to the teeth, because that determines the prescription for the appliance to be run throughout the course of treatment. So that's the day when you take your time. When a case like this presents, it seems like a very straightforward, easy case of congenitally missing lateral incisors. The crowns look parallel, the incisal edges look even. If we just close the diastema, we should have a good site for implant placement. But if you don't look at the radiograph closely, you might not realize that this central incisor cants off towards the distal significantly. So it's another example of how we need to treat to the radiograph, and to an orthodontist that means placing the brackets in the long axis of the tooth, not according to the incisal edge, which in the typical adolescent patient with a fully healthy dentition, that's a good guide, but not in an adult after years of wear. So it may be just a matter of placing the bracket somewhat crooked, if you will, but this is really in the long axis of the tooth. And in that way, the arch wire deflects, and when you run through the sequence of wires and elastics and all the things we do in the sequence of orthodontic treatment, that tooth will automatically upright. But that bracket placement visit is the important point for prescribing the appliance. And here we see some months later, space is closed, brackets are paralleled. That would indicate that the teeth are upright properly. And you see the discrepancy in the incisal edges. Had we used them as a reference point, they would be level, but the teeth would not be parallel. And if you look at the radiograph after that movement, you can examine the lamina dura that appears on that tooth and note that it widens towards the apex, meaning the movement was greater there and a lot of root torque was effected, allowing implant placement into very tight confines. Now, those are some of the issues regarding spatial relations, and I use that to point out how important precise and accurate tooth position has become since we are conserving teeth now through implant therapy. But let's consider some of the other things we can do utilizing orthodontics, again, still preparatory to the placement of an implant, how we can modify tissue to site develop a better environment for the placement of an implant. Now, we know that we can use eruptive type movements to effect changes in the hard tissue, and by erupting teeth like this, we can invert infrabony defects into suprabony situations, and that hard tissue changes have been well quantified. The alveolar bone comes under tension as a result of the periodontal ligament stretching and pulling on the bone. In this clinical situation where a lateral incisor was force erupted, later a periodontal flap was elevated, it shows how the alveolar bone reconfigures and changes its morphology in response to tooth movement. The crestal spicules of bone are angled incisally, denoting how the bone tissue accompanies the tooth in its movement. So through tension imparted by the periodontal ligament, we can cause bone deposition. Similarly, on the soft tissue side, through a process of sulcular eversion, we can grow gingiva and change the location of a gingival margin. By erupting two teeth, as you see here, which the lateral incisor and the cuspid are long, apico-incisally, we can erupt these teeth, and through the process of sulcular eversion, again a response to tension movement, that sulcular epithelium keratinizes and forms healthy attached gingiva. So we can cause tissue changes on both the hard and soft tissue arena. And it's important to know as well that these changes in tissue morphology can occur even in the presence of periodontal inflammation. Usually periodontal inflammation is an enemy of orthodontic movement, and attachment can be lost when teeth are moved in the presence of inflammation or pathology. But because of the unique nature of straight eruption, because the teeth are under tension and there's no pressure involved, there is a plaque front that is moved away from the attachment apparatus, and it's not insulting to the periodontal investment. So we've seen that orthodontic extrusion of teeth, even in the presence of periodontal pathology, can still have these positive effects, hard tissue and soft tissue. So that is a unique form of movement that it can affect that. And that's important when considering cases like this, where we have two central incisors in this particular case, which are considered hopeless teeth, as you'll see. And severe periodontal involvement renders these teeth slated for extraction. But even when they're hopeless, if we think a little differently, that doesn't necessarily mean that they're useless. Here the orthodontic appliance is geared for extreme extrusion to the point of orthodontic extraction, and utilizing the small amount of attachment that we may have, maybe only in the apical third, to impart tension to that crestal bone and to the gingival tissues, remodeling the site so that what would have been a type 3 extraction socket, probably void of buccal plate, is now converted into a very nice site for implant placement. And in this case, we harvested the bone from these osteotomies and did histology to find that when you utilize the body's reparative capacity and the body's ability to alter morphology in response to orthodontic movement in this case, the body will remodel tissue, and in this case bone, to form living and vital bone, as we found in histologic section. So that's very important when you get to the level of osseointegration. At the clinical level, rather than being faced with type 3 extraction sockets, void of labial plate, and in need of surgical augmentation, through orthodontic site preparation, we now have effectively ridge augmented the case, allowing for ideal implant placement, which of course affects the outcome and final restoration. So we can remodel these sites and effect site development through orthodontic movement, again preparatory to the implant placement. So those are some areas where the orthodontist could be involved, and still in that arena the orthodontist is involved in setting the case up, either through tissue modification or spatial relation, or both, setting the case up to receive an implant. Still the normal sequence that he's used to. But what happens when the orthodontist now starts to consider maybe getting implants in preparatory to his treatment and utilize those implants as possible adjuncts to his mechanotherapy? I like to start this sequence with Newton's third law, which we know states that every action has equal and opposite reaction. This is important to every orthodontist because historically we're always trying to move certain teeth while other teeth remain stationary. And the way that we do that is by managing anchorage, which is defined as a body's resistance to displacement. So when the anchor teeth are equally apt to move as the active teeth, we have to manage appliances in certain fashion to prevent unwanted movements. We define the orthodontic anchorage system depending upon how we intend to utilize space. If we consider a case of a bicuspid extraction here, depending how we utilize that extraction space defines the class of orthodontic anchorage historically. So if we say that 2/3 or more of that space can be utilized for posterior protraction, We'll let the back teeth go forward into that space. That's a minimal anchorage situation. If we decide that we'd like to split the extraction space between retraction and protraction, well, we would call that a moderate anchorage situation. And as you might anticipate, if we say we'd like the anterior teeth to retract into that space 2/3 or more, that's called maximum anchorage. These are the cases that can be challenging from a mechanotherapeutic standpoint. We have to put a lot of anchorage-sparing, anchorage-preserving ingredients into the appliance, such as headgears, lip bumpers, tip backs, toe-ins, cinch backs, all kinds of things that orthodontists employ, making it technically challenging. However, when we consider the possibility of using integrated implants, which are immobile, and we consider using them as part of an anchorage system, now that introduces a new class of anchorage. In addition to the historic classes of minimal, moderate, and maximum anchorage that I just showed you, now we have the possibility of attaining absolute anchorage. The implication of absolute anchorage is that the appliance would become entirely under the control of the orthodontist, and the predictability of the outcome would rise dramatically. Compliance dependence is eliminated. Let's look at the natural dentition and how an orthodontist would manage anchorage, and then we'll contrast that to how the rules are being rewritten when you employ implant anchorage. In this particular case of a 30-year-old female, her chief complaint is one of a midline discrepancy in the maxillary arch. And so a setup was done to diagnose the situation, and we determined that the upper left cuspid tooth, which in fact is a restoration, is missized. It's larger than its contralateral brother, if you will, and we determined that that tooth is too big mesiodistally, and that's the source of the midline discrepancy. So what we'd like to do is constrict the size of that cuspid in a new restoration and walk the teeth to the patient's left orthodontically to effect a midline correction. So the way we do that, the cuspid tooth, which here is a pontic, is provisionalized and space is provided for the midline correction. And by utilizing the orthodontic appliance and tying the teeth together, we effectively splint the entire quadrant for the purpose of moving just the lateral incisor. So we manage the anchorage in a situation like this by outnumbering the active teeth. Here we've got 4 or 5 anchor teeth held together for the purpose of moving one active tooth. And you can see the elastic applied to the lateral incisor to effect that distal movement. When the lateral incisor is retracted, we then join it to the orthodontic appliance to the anchor segment, again outnumbering the active teeth, which is now the central incisor, retracting the central incisor to open up the midline, at which point we could go contra-arch, contralateral, and move the other central over. But the point is, the anchor teeth always outnumber the active teeth in conventional orthodontics. Because if that didn't happen, and if the active segment overpowered the anchor segment, such that the anchor segment were to slip forward in any way, in the end, you wouldn't get the midline correction, and the orthodontic result is compromised. So you go through a temporal sequence to preserve anchorage, and it's time consuming and technically challenging to effect the exact movements that you want. Well, now let's contrast that to how that might differ from an implant anchor system. Here's a case with an adult and a semi-mutilated dentition, a lot of crowding anteriorly, but she has a molar restoration that is implant supported. And here, in this case, not even in occlusion, but let's consider how we might utilize that implant for the purpose of retracting these teeth and alleviating her crowded situation. Well, as I showed you conventionally, what we would do is sequence it. If the molar were a natural tooth, we would first retract the bicuspid and then join it. Then we would retract the cuspid and join it, and then we would align the anterior teeth to preserve the anchorage. But when the molar is implant supported, the rules are quite different, if there are any rules. What you see here is the placement of the orthodontic appliance, and I'm employing elastics simultaneously to all the teeth. So here is an elastic from that implant molar to the bicuspid, a separate elastic to the cuspid, and a separate elastic simultaneously to the lateral incisor, so that what we used to sequence out temporally is no longer necessary, And the reason being because the anchor system can take tremendous load. There is no chance of that anchor system slipping once it's integrated. And it's not to say in any way, shape, or form that the teeth are being loaded more heavily because they're against an implant. The teeth are receiving the exact same force that they would have in a natural dentition. But what the difference is that now we can do simultaneously what we used to do in sequence. And the reason for that is because the implant can take a lot of force. And so here we achieve alignment with great expediency. Now that is a technique known as direct anchorage, which we'll look at a little more in depth now. Direct anchorage implying that the force originates from the implant itself. We're either pushing or pulling directly on the implant. One of the studies that we performed in the early days of this was utilizing an implant for space management. Here we see a quadrant with space, and this molar is a restoration that is implant supported. And by virtue of this open coil spring, we're pushing the cuspid forward in this case. And then subsequent to that movement, we utilized an elastic for the purpose of retracting the premolar against the same implant supported restoration. So we're testing the implant to see how well it withstands both pressure and tension stimuli. So when we looked at that at the radiographic level, we saw that whereas the teeth showed signs of movement, widening of ligament spaces, disappearance and reappearance of lamina dura, the teeth became mobile and the teeth moved, so all those signs were exhibited by natural teeth, but the implants in fact did not show any of those signs. They acted as perfect anchors. Since that time there have been many other studies in the literature to support that implants provide excellent anchorage. Of course, Gene Roberts out of University of Indiana is one of the pioneers using implants as anchorage. He proposed this a long time ago. But we've also seen that in addition to withstanding orthodontic load, implants in fact seem to adapt to orthodontic force. And there's bone densification around these units, some sort of a response to the stress patterns that are set up, that implants find it favorable. So that's useful information for this modality. Let's consider other case types of direct anchorage, putting force directly on implants. In a 55-year-old adult, a case like this by conventional orthodontics is a very difficult situation. When the cuspid slips the mesial contact and the teeth experience accelerated mesial drift and now reside somewhat in the buccal vestibule, this is very difficult to recapture by conventional orthodontics. And it might entail a couple of things to get that cuspid back into alignment and into function. First of all, many orthodontists might treatment plan for the extraction of a first bicuspid, which is pretty costly in a semi-mutilated dentition already. And secondly, the patient may need to wear an appliance in the maxilla for the purpose of anchorage to provide force by virtue of a class 3 elastic to retract that cuspid into the extraction space. So by conventional orthodontics, the treatment options are not terribly attractive, and that's why a case like this becomes difficult to treat. But if we treatment plan differently, if the orthodontist is in consultation with his implant team and they decide that the placement of an implant preparatory to orthodontic movement might benefit the patient, well, it certainly would. And so here an implant is placed as an anchor system distal to the active teeth and integrated, and a provisional restoration placed, and now you see a sectional appliance retracting 3 teeth simultaneously against one anchor unit, which is the complete opposite of the anchor systems we dealt with traditionally. Now the active teeth outnumber the anchor tooth, although the anchor tooth is an implant. And in short order, this is about 8 months of movement, the teeth are retracted as one together, and then space is accommodated by completing the arch and rounding out the arch form. So the patient didn't have to have an extraction, nor did she wear an appliance in the maxilla at any time. It completely changes the orthodontic treatment plan and renders a difficult situation to really somewhat of a simple one. Another interesting situation for direct anchorage, now a patient, an adult, in an anterior crossbite, a potential class 3. These cases are almost automatically orthognathic cases. But this one is not a very deep anterior crossbite, nor is it a large reverse overjet. It would be nice if we could retract all these teeth, but by conventional orthodontics, we don't really know how to retract the whole arch. To this patient's benefit, though, he's missing a molar on each side. The lower left prosthesis is scheduled to be retreated. So if we place implants preparatory to the movement, and here you see the placement of those implants somewhat distal to the ideal location, planning for movement, we're now going to retract 10 teeth plus a molar against 2 implants, the total opposite of what we thought conventionally. And by very simple round wire orthodontic mechanics, retracting all at once, no orthodontic sequence whatsoever, in 11 months, all 11 teeth are retracted and the crossbite is jumped, saving the patient from an orthognathic situation, but more importantly, effecting a dramatic movement through very simple mechanics. Well, these direct anchor systems, which again are as a result of placing force directly on the implant, they can be implant driven when there is an edentulous location or a restoration that's being planned, but more recently we've gone to mini screw applications known as temporary anchorage devices. And these mini screws offer many advantages to the implant driven systems, so when feasible this is a very convenient modality. Such as a situation like this, an elderly patient with a severely atrophic mandibular arch. We'd like to retract 6 anterior teeth, but there are no locations for implant placement at this stage. We can place mini screws simply by hand threading bilaterally and tightening down, and then loading these immediately to retract 6 anterior teeth against 2 mini screws and effect a very nice movement. Here, pre-treatment, you see a very obtuse lower incisor to mandibular plane angle. Post-treatment, that becomes much closer to a right angle, which we prefer. And just as importantly, we saw in many of these cases, because the screws are down low in her case, apical to the center of rotation of the teeth, we also effected a significant intrusion movement, which historically is very difficult to achieve in adult dentitions. So the application of these screw technologies will expand, no doubt. I was in on the publication of a molar uprighting paper many years ago where we were considering in molar uprighting treatment planning when the orthodontist would elect to upright the crowns to open space for restoration, and when do you elect to close the space by protracting posterior teeth. Well, through the utilization of these mini screws, space closure has become a very realistic option. A movement that was traditionally very difficult to effect is now a viable option. And in this case, an adult female who underwent orthodontic therapy for the purpose of having implants was told when she met the implant surgeon after orthodontics that these ridges were too atrophic and narrow or knife edge, that she wasn't an implant candidate. And so she came to our office to consider closing space to achieve an intact arch. So through the utilization of temporary anchor devices, because implants are not an option, we were able to use sectional orthodontic mechanics. No load is placed on the anterior teeth, and these devices are a very effective way to put force on the posterior teeth, effecting protraction and space closure in a very efficient and time-efficient manner. But we still may elect to upright crowns by distal driving, and we can still use these temporary anchor devices as well, here into the maxillary tuberosity as an adjunctive means to apply force, open the molar space, opening up a nice location for subsequent implant placement. The flexibility in using TADs is that their location is widely diverse, and wherever it's convenient for orthodontic force application, we can place these screws. And other cases will arise when we want to do more extensive movements, for instance, a case with a whole quadrant to retract for the purpose of getting this lower cuspid back into function. We may go to multiple screw usage and skeletal anchor systems, or these mini plates. And this is nothing new to the oral surgeons who've been using fixation plates for many years. Now they're modified for orthodontic convenience. The advantage here is that the screws to fixate those plates are really quite small, and there's much less chance of root injury in their placement. The disadvantage being that a flap surgery is necessary, although it is a very simple one. So here you can see the placement of a skeletal anchor plate and then closure with the loop in the plate exposed, and placement of an orthodontic auxiliary for the purpose of retracting 5 or 6 teeth as a unit. And here you can see some of the gingival changes, not to be confused with inflammation, again, sulcular eversion and gingival formation. In short order, then, we've achieved an intact arch and retracted a quadrant of teeth with relative simplicity. Let's consider lastly now some of the techniques known as indirect anchorage, whereby we can utilize implants to in turn stabilize teeth that we then place force upon. So in this case of an integrated palatal implant, we utilize that implant to stabilize dental units, which in turn will have force applied to them for the purpose of tooth movement. Palatal anchorage devices have come into vogue over the years. There were 2 that received popularity in the U.S. One was the Implant by Nobel Biocare, the second the Straumann Ortho System. The latter of the 2 is the one that I prefer to utilize because that is an endosseous implant design. The Implant by Nobel was a subperiosteal implant design, which had some success, but I find that the latter is more predictable. So I'll share with you some of my findings there. The placement of the endosseous type implant, mid-palatal, is quite simple, achieving anesthesia locally with simply a carpule of anesthesia, and then using a soft tissue punch to locate the implant placement. There is no incision or flap or sutures utilized. This is a flapless punch and place implant technique. We then go with a round burr to make a small indentation so that the spade doesn't skid, and you drill to depth in one motion utilizing these implant spades that are designed for the placement of that implant. And here is the preparation of the osteotomy, which leaves a shoulder for full seating of this implant, which is carried by hand to the osteotomy and screwed down mid-palatal into very dense cortical bone, which is void of any vital structures. So it's a very safe implant placement. And here you can see it in lateral ceph, well incorporated in bone. And the protocol is to wait 8 to 10 weeks for integration of this implant. During that time, other orthodontic mechanotherapies are occurring, leveling and aligning, so there is no time wastage or addition of time by going to an implant. Subsequent to the integration, we go to the lab phase, in which case an impression is taken utilizing this impression coping, which we lift off in an alginate impression, place the implant analog, and pour the model that goes to the lab for the fabrication of a transpalatal arch, bonded to the teeth according to the treatment plan. Tremendous flexibility, and then carry that to the mouth and affect the orthodontics. So the management of this implant is really quite simple, but the effect it can have on orthodontic treatment is dramatic. And so let's look at a few cases now where that applies. The first, most obvious would be with anterior retraction. Here's a patient, class 2 situation, considerable crowding, large overjet, arguably an upper bicuspid extraction case, which I effected here. By placement of the transpalatal arch, molar to molar, attached to a mid-palatal integrated implant, we can retract all 6 remaining anterior teeth and align them as one in very short order and with great efficiency, without any posterior protraction. So a case of absolute indirect anchorage. And when you see a big increase in the interincisal angulation here, that is indicative of a lot of dental retraction. Now, there was absolutely no posterior slippage, as was desirable in that case. Consider the opposite movement of posterior protraction. In an adult patient like this, who's missing upper second bicuspids, has residual E space from the deciduous tooth, the E space is larger mesiodistally than would be the space for the second bicuspid. So to protract into that space and close down for the purpose of having a normal size second bicuspid replacement is desirable, but this patient was inquiring as to whether complete space closure could be affected, which is a significant movement. Well, with the advent of this technology, now you see a mid-palatal implant attached through the transpalatal arch to the upper first bicuspid lingual surfaces, and then using auxiliaries on the palatal and buccal aspects of the teeth to effect space closure in a very efficient manner. And here you see the teeth moving forward without movement of the anterior teeth because there's really no force placed on the anterior teeth. So a significant protractive movement is effected with really relative ease through the use of a single implant, and a small implant at that. Distal driving presents certain challenges to orthodontists in the conventional arena because this is a movement that we'd love to be able to accomplish, but without adequate anchorage, it's something that always has untoward side effects, and we always encounter some degree of anterior flaring. But if we drive against an integrated implant, here again mid-palatal, now bonded to the first bicuspids, by virtue of open coil springs, we can drive these molars distally without even having an appliance on the anterior teeth because there's no force application there, and you can see that these teeth move very effectively. Subsequent to the movement of those teeth, we can flip the TPA, transpalatal arch, now pick up the molars, complete the appliance for the purpose of retracting the remaining aspect of the arch and aligning those teeth accordingly. So this becomes a very effective modality in an arena where orthodontically we were challenged historically. In terms of a mutilated dentition, periodontal involvement, and partial edentulism, patients like this who present with a severe protrusion historically may not even be orthodontic candidates because the treatment plan for a patient like this might be too invasive. It's either an orthognathic case to advance the mandible or an extraction case to remove bicuspids and make room for retraction of the anterior teeth, but in the absence of a posterior anchor segment, that's not even a possibility. So a patient like this, who's 63 years old, looks like that for good reason. And here you can see the posterior teeth, which are hardly even abutment teeth, let alone predictable anchors. But by utilizing this technology, placement of a mid-palatal implant and attaching a transpalatal arch to now stabilize those compromised molars, we can effect a significant retraction of 10 teeth simultaneously against 2 molars that are indirectly absolute anchors and they don't move. That's about 9 months of movement there, and then having retracted those teeth out, we can again flip the arch to now pick up the second bicuspids, and through use of open coil springs on the arch wire, we can drive those molars and regain the space that was lost, so that every tooth in the maxilla at that point has been driven distally, no protraction whatsoever, and then convert that tooth into a prosthesis, that arch into a prosthesis. So by virtue of the utilization of one small implant, mid-palatal, we can retract and move every tooth in the arch in one direction, sort of conflicting with Newton's third law. Here you see the result facially. So that renders a patient that wasn't an orthodontic candidate suddenly very amenable to treatment. Lastly, I'd just like to demonstrate that these palatal implants do have bimaxillary capability. In a patient like this with significant crowding, the treatment plan might be a non-extraction case, but the patient is extremely protrusive, as you can see in the cephalogram, and her chief complaint is one of facial fullness. If we were to treat that non-extraction, clearly the dentition would expand and cause a greater protrusion. So by virtue of treatment planning for a 4 bicuspid extraction and then utilizing the implant to indirectly anchor the maxillary molar, we can close space in the maxillary arch using class 1 elastics, molar to molar, to retract, and then close space in the mandibular arch by virtue of a class 3 elastic to the maxillary molar, again, which is indirectly anchored. So the source of anchorage is the maxillary molar, in this case, for both arches, and the retraction of dual arch dentition against that one molar is easily accommodated. And here you can see cephalometrically the movement, dual arch retraction into the extraction space, effecting a very significant alteration of the pattern anteriorly. Any posterior slippage in that case would not have affected the facial changes that we were seeking. So in summary, ortho implants do possess certain very attractive features. Most notably, we can expand treatment possibilities. Expanding treatment possibilities is the reason throughout any modality of dentistry or medicine to employ new devices and new technologies. When you can effect treatment outcomes that were not previously attainable, that's the reason to do it. Secondly, we can eliminate compliance dependence by achieving perfectly predictable absolute anchorage. We no longer rely upon the patient to change elastics, wear headgears, or do any sort of things that we depend on them for our outcome. We have shown that this is an easy implant to place and to manage. Certainly any surgeon who is experienced at conventional implant placement will find this implant very easy to utilize. The mechanotherapy orthodontically is greatly simplified. All of the adjunctive things that we put into our mechanics to preserve anchorage become obsolete and superfluous. And lastly, treatment time is decreased significantly by virtue of group movements or en masse movements, no longer sequencing teeth in their movements to preserve anchorage because that's no longer necessary. So many features of ortho implants that will be utilized in orthodontics are very attractive to us. Now, in closing, I'd like to show a few situations now which I hope will point out that when implants are utilized as part of the orthodontic treatment, the sequence of therapy changes dramatically. And this is why I stress that the orthodontist should no longer initiate the case and not introduce the patient until implant placement is necessary. Because if the orthodontist is part of the treatment planning team and he considers placing implants earlier in the sequence, his treatment will be very different. I like to utilize this case, which came to me for a second opinion. A 19-year-old girl who had been in orthodontic therapy for 4+ years. Her father's asking me if they're getting anywhere with this case, if the treatment seems to be progressing, because he doesn't detect that it is. So this patient has a significant partial edentulosum congenitally, and we can see a midline discrepancy, that the maxillary midline is off to the patient's right. She's missing both lateral incisors and also missing a lot of teeth posteriorly. So I analyzed this 19-year-old patient and concluded that in fact the treatment sequence, although the appliance is being managed properly, there's not a lot of activation in that appliance, and I don't see the midline shift being affected because I believe the orthodontist is struggling with a lack of anchorage. And had he considered placing implants before the appliance, the treatment would have been much easier. Now, it's understood that the lateral incisors are not ready to be implanted because the tooth position in that region is not yet ideal, and the teeth would conflict with the implants. But posteriorly, we pretty much know where those molar and premolar implants are going to go. So I explained to the patient and the parent that I would sequence this to place posterior implants first, provisionalize those implants, and then place the orthodontic appliance, effecting a midline shift very expediently and with greater efficiency. An example of how treatment planning with implants changes the sequence. Now the orthodontic therapy is not the first step. Let's consider a second case where that might apply. Here's an adult patient missing bicuspids with retained deciduous teeth. Typical sequence by conventional orthodontics might be that the orthodontist receives the case, analyzes the situation, and decides to remove the deciduous teeth, as we do, and close the space down to premolar size, and then refer the patient for implant placement. There's already one implant in the upper left, but the other three need to be treated as well because these deciduous teeth are mobile. But I suggest that that sequence is not the optimal sequence for efficiency, and I present to the patient that we should place the implants first, preparatory to orthodontics now. And you can see the implant placement, particularly in the lower arch, mesial to the extraction socket, anticipating posterior protraction. Provisionalization of these implants, again, before orthodontics, and now I know exactly the size of the space that we'd like to affect because the restorative dentist has programmed it into his provisionals. And now the orthodontist comes as the third step, not the first step. The appliance is placed and protractive force is put on these teeth. And since the upper anterior teeth are in reasonably good alignment, a nice advantage is that the patient doesn't even need braces on those teeth. So we protract the space out, it closes down a bit, and we achieve final restoration with great efficiency. Another example of implant placement preparatory to orthodontics, not the conventional scheme. So that sort of sequence would change orthodontic treatment. And again, I hope illustrates how the orthodontist can benefit by becoming part of the implant restorative team from the onset, not taking charge of the case in the beginning and not realizing the advantages of utilizing the implants as part of mechanotherapy. Much of what I've discussed in this presentation has been published and is available at my website, which I would encourage you to visit. And that concludes this aspect of the discussion. Thank you for your attention.